Okay, welcome to this podcast for Chapter 18. We're covering Medicare and Medicaid. Be advised, this is one of the larger podcasts. There are only 20 pages of this Chapter 18 in the textbook, but there's a lot of information to convey to you. So we have 41 slides to cover. Again, I'll try to get them through as quickly as I can. Bear in mind that Team 2 has been assigned to present a videotape case presentation involving this chapter. The patient in the case is named Helen. She's on Medicare. Even though she's on Medicare and she's been in the hospital, she still has to pay out of pocket about $2,500. So this Team 2 will present this case and discuss the ramifications of Medicare and Medicaid on patients and what they have to pay. There are 4 IRATs that come from this particular podcast, so listen carefully. There are 2 tables I want you to focus on for Chapter 18. There's Table 18.1, which involves estimated Medicare expenditures by service in the year 2014. And also in Table 18.2 are the estimated Medicaid expenditures by service in the year 2013. So that can give you an idea of what kind of money we're talking about here, which is substantial. Again, there are 41 slides, 4 IRATs that we'll cover, and there are 16 objectives. So you can get some idea of why I have so many slides here. First, we'll talk about Medicare, and then we'll talk about Medicaid. Bear in mind, Medicare is something that folks earn when they turn 65. They're covered by Medicare if they have been working. It also depends on how much they put into the program. So Part A is usually paid for. Part B, you usually have to pay some to get into it. We'll discuss that. When we finish Medicare, we'll move on to Medicaid. Medicaid is a federal state program. Federal money is given to a state to take care of indigent folks. The states have to follow certain rules mandated by the federal government, what services they must provide. The state can determine what services they might want to give Medicaid patients in addition to those federal mandates. Here you see getting back to Medicare, here you see the legislative history of Medicare. This is Title 18, Health Insurance for the Aged and Disabled, often known as Medicare, of the Social Security Act, was passed in 1965 during the Johnson administration, shortly after Kennedy was assassinated, to complement the retirement, survivor, and disability insurance provided by the original 1935 Act. The concept of Medicare originated in 1952 when Truman abandoned his advocacy for a universal health program, but suggested a limited program for Social Security beneficiaries. A 1957 bill by Republican Amy Forand initiated the legislative activity Social Insurance Program for Health Insurance for the Aged that eventually became Medicare. Hearings on the bill in 1959 created a consensus belief that the aged faced several difficulties obtaining health insurance, which needed federal action. The Republican Representative Wilbur Mills of Arkansas, an ardent opponent, designed a compromise that was able to pass only because of the landslide victory of Lyndon Baines Johnson that increased the Democratic majority. The compromise, a compulsory health insurance program, compulsory, you have to pay this as you work, financed by payroll taxes, Medicare Part A voluntary insurance program for physician services subsidized with general tax revenues, Medicare Part B. So again, Medicare, once you become 65, for the most part, is free. So you sign up and you get this. You have to make the decision whether you want to get Medicare Part B when you turn 65, and you have to pay for that, usually out of your Social Security. Medicaid is something completely different, a means-tested health insurance program for the poor administered by the states, although they do get federal money. Most proponents believe that Wilbur Mills' compromise would provide a boon to the federal revenue coffers. In 1965, the projected cost of the program in 1990 was $12 billion. Adjusted for inflation, actually it turned out to be $110 billion. So it's a very expensive program, almost an order of magnitude more than they thought it would be. Medicare, again, Part A is hospital insurance. Hospital insurance, I want you to remember that. Pays for care provided to patients in hospitals, skilled nursing facilities. That's limited. Usually when a patient gets out of hospital, like for a car accident, they need some physical therapy or something, so they get them to the nursing home. And it pays in a limited fashion for nursing facilities. It also pays for hospices. That doesn't mean the nursing home bed. That just means for the hospice service. So if somebody is working for a hospice service, they go to your home. It is paid for by Part A, all of it, and home health care programs. Part B, again, is something that you pay for out of your Social Security. It's a supplementary medical insurance. It provides coverage for physician services, outpatient hospital care, and many other medical services not covered under Part A. Part C is Medicare Advantage. It was added in 1997, originally known as Medicare Plus Choice Program. It expanded the ability to participate in a wide variety of private health plans, including health maintenance organizations and preferred provider organizations. Now, for people who've been in the military, they're covered by something called TRICARE until they turn 65, and they have to get Medicare when they turn 65, and then their TRICARE becomes like a Medicare Advantage program. So you may see a lot of veterans who've done 20 or more years, and they ask about Medicare Advantage programs. They don't need it. They have TRICARE for life. Also, there's Part B. It's a prescription drug benefit. The Medicare Prescription Drug Improvement and Modernization Act of 2003 established a new prescription drug benefit. This is something that you can sign up for. There's something called the donut hole that takes a chunk out of what you can be reimbursed. For veterans who have Medicare, they also have TRICARE as a Part C. Veterans also can get Part D through TRICARE, so they just send off their prescriptions usually to a mail order, but they can also get it through Walgreens or such through TRICARE for life. Now, getting more into eligibility for Part A, the hospital insurance. If you're 65 years old, there's no premium. If you're a U.S. citizen or permanent resident and person or spouse that has worked greater than 10 years in Medicare-covered employment, you're receiving or eligible to receive benefits from Social Security or Railroad Retirement Board, and you had Medicare-covered government employment. Or you pay a monthly premium if you don't qualify. Received it. Part A does cover other things like disability benefits from Social Security or Railroad Retirement Board for at least 24 months. No waiting period for Lou Gehrig's disease patients or end-stage renal disease that requires dialysis or transplant. Part B, supplemental medical insurance, eligible for Part A and pay a premium. Not eligible, but 93% have Parts A and B. These social supplemental medical insurance recipients have premium deducted from checks. So these are other kinds of patients that have diseases or conditions that have kept them from working. And so these are like supplemental plans where they at least get some benefit from Medicare. Then there's Medicare Part C and Part D, which we've already talked about. You're eligible for Part A and choose from approved MCO, managed care organization. So you may see a lot of commercials on television for these Medicare Advantage programs, like through AARP, Humana, and so on. And you may need to pay an additional premium. Some of these you don't have to pay a premium, but they don't really give you too much. Maybe a discount, but it really kind of channels you to see a particular kind of provider who may be expensive. Part D is a prescription drug benefit. If you're eligible for Part A and you pay a premium, it may not be required. I'm sorry, I take that back. It's not required to get Part D. It's voluntary and you do pay a premium. If you're eligible for Part A, you're eligible to volunteer to get this. Again, if you're a veteran through TRICARE for Life, Part C and Part D are paid for by the Department of Defense. It's a nice benefit if you're a veteran with more than 20 years of service in. Financing. Part A, paid from the HI Trust Fund. Beneficiary cost sharing. And the trust fund is financed by payroll taxes. Employers and employees each pay 1.45% of payroll costs. Self-employed, both parts, 2.9%. If you're self-employed, you still have to, like you have your own business, you have to pay both of these parts out of your own money. Part B, the SMI Trust Fund, general federal revenues. There's premiums, there's cost sharing for this. Again, you don't have to get Part B when you get Medicare, but it's actually it's a bargain. You don't want to get stuck paying for physician bills when you're older than 65. So most people do get Part B, even though it's just voluntary. The premiums are going up, and they're tiered according to how much money you have every year. Medicare, the administration, the responsibility of the U.S. Department of Health and Human Services. Eligibility and enrollment is through the Social Security Administration. Administration policies and general funding is through the Centers for Medicare and Medicaid Services, headed up by Dr. Price. The U.S. Treasury manages the HI and SMI trust funds. To be reimbursed, providers must comply with conditions of participation. We'll get into that more, like capitation or assignment. There's agencies of state governments certify compliance, like a physician, an HMO or HCO is doing what they should. Providers get paid after filing claims to designated administrators contracted by CMS and in-state insurer. Administrators then determine reasonable charges for covered services to reimburse providers. Part A, again, we're talking about different parts, is inpatient hospital care. It's based on a benefit period which begins on the day the patient enters the hospital and ends. When a person has not been a patient in either a hospital or a skilled nursing facility for 60 consecutive days, if the person resides in a nursing home for 60 consecutive days without receiving skilled care, that's a benefit period. A beneficiary can have several benefit periods in 1 year, and there's no lifetime limit on the number of benefit periods. There's deductibles and co-pays depending on the length of stay. So again, Part A really only pays for, I think, like 80% of inpatient hospital care. The patient has to eat the rest, the other 20%, unless they have Part C that covers it. Covers all emergency care, but not hospitalizations, while in other countries. So a lot of elderly think they can go overseas to Europe and their Medicare will cover any expenses they incur, like in Europe, and it doesn't. CMS recommends separate health insurance, so you can, for example, buy health insurance for the time period that you're on a trip to Europe, but a lot of people don't know that and don't get it, and it comes back to haunt them. There's a blood deductible. Patients must replace first 3 pints of blood used each year, either from themselves or somebody else on their behalf. Services cover 90 days of medically necessary inpatient care per benefit period. Each patient has a lifetime reserve of 60 days to be used if hospitalization exceeds 90 days in one benefit period. There's emergency services, lifetime limit of 190 days of inpatient psychiatric hospitalization that is also provided, that is not provided in general hospital. Part A, the skilled nursing facility care, 100 days, remember that, 100 days of skilled nursing care per benefit period must be preceded by at least a 3-day hospitalization and within 30 days of discharge. It requires daily skilled care or rehabilitation can only be provided in a skilled nursing facility. So I really don't want you to think that Medicare pays, at least Part A doesn't pay. I don't want you to think that Medicare Part A pays for nursing home care. It does, but in a very, very limited fashion. So like the example, you're in a car accident, they want to get you out of that very expensive general hospital as quick as possible. They may put you in a skilled nursing facility, which is less expensive for a very limited amount of time for like physical therapy or occupational therapy or something like that, even some other forms of therapy. Now, on this particular slide, there will be an IRAT that comes from this slide, so listen up. The covered services under Part B, physician services are provided in most settings, office, hospital, nursing facilities at home are covered. Outpatient hospital services like x-rays, labs, PT, occupational therapy, physical therapy, dialysis, ambulance, transport. Preventative services like vaccine, cancer, and osteoporosis screenings, diabetes monitoring, and limited care by chiropractics, optometrists, podiatrists, and dental surgeons. So when you think about it and you're signing up for the first time for Medicare, or you're talking to your patients about this, it's a pretty good idea to sign up for Part B, even though it's just voluntary. Most people recommend that everybody gets Part B. Services not covered: routine physical and vision exams, hearing tests and hearing aids, and routine dental care. So again, like other forms of healthcare insurance, even when you're younger, usually these services are not covered. You have to pay for them out of pocket or buy some kind of supplemental health insurance. Now, I want you to know all of the services covered by Medicare Part B. I want you to know that ambulance transportation is covered, outpatient hospital services are covered, physician services are covered, and ambulance transportation and physician services are all of these are covered by Part B. The cost sharing with Part B, there's a monthly premium. If you're older than 65, you signed up for Medicare and you're also getting Social Security. Typically, you can tell the Social Security, oh, I'm getting $1,000 or so from Social Security. Take out the monthly premium for Medicare Part D out of my Social Security and just send me what's left in a check to me at my address or to my bank. It's a nominal annual deduction, coinsurance of 20%. All of the non-covered services are charges. There's assignment. Medicare participating physicians agree to accept only what Medicare pays, which is 99% of the physicians enrolled in Medicare to provide services. So Medicare sets a price they'll reimburse physicians. If a physician does not accept assignment, then the patient needs to know that, and then they're on the hook to pay anything more that the physician wants to be paid. So Medicare will pay part of it, and the patient will have to pay more if the physician has not agreed to assignment. And as you can see here, the patient can be billed for the difference, the balance billing. However, by law, they can only be charged a maximum of 115%, which is less in some states of the approved charge, which is 5% less than Medicare participating physicians. So this balance billing is limited. Part C, Medicare Advantage. It too is a good idea to have because Medicare generally will pay 80% of costs. The other 20% is usually paid for by a patient out of their own pockets. So if they go to a hospital, they have a bill for $1,000. Medicare will pay for $800, and the patient will have to pay about $200. And again, if the bill goes up, you can see how it would quickly cause a burden for these patients in Medicare. Increased options for Medicare beneficiaries similar to those of non-Medicare plans, HMOs, PPOs, etc. The plan must provide minimum of traditional Medicare benefit, excluding hospice care, without imposing any other out-of-pocket costs. If the plan is cheaper, they must pass on savings to the beneficiary by lower premiums or cost sharing or additional benefits, or return it to Medicare. Even with better coverage, Medicare Advantage beneficiaries save about $100 per month. Number of plans have decreased since 2000, mainly because Medicare limited increase of payments to plans despite increasing administrative requirements. Part D, that started back in January 1st, 2006, is a voluntary enrollment in the prescription drug benefit. Beneficiaries pay an additional premium. Coverage by enrolling in a freestanding prescription drug plan while in the traditional Medicare program, or joining a Medicare Advantage plan that includes a PDP. So again, quite honestly, Part C and Part D are kind of intertwined. If you have a Medicare Advantage plan, you may have both Part C and Part D in it. But again, it depends on the Medicare Advantage plan. So like with veterans, with TRICARE for Life, that really is Part C and Part D. Like Humana or AARP. Part D, there's a $360 deductible in 2016 that you have to pay before you get any money back. There's a coinsurance of 25% on the next $2,950. There's this donut hole that I want you to be aware of. Beneficiaries pay 100% of additional costs up to a total out-of-pocket expenditure of $4,850. After $4,850 of the out-of-pocket expenses, beneficiaries pay either 5% coinsurance or $2.95 generic, $7.40 brand copayment, whichever is greater. So there is, even with Part D, there's some that you have to pay. This is generally something that pharmacists get into when they're talking with their patients. We'll talk about this a lot more in the pharmacy management class next year, but be aware that not all patients is it a good idea to pay this Part D. It can get expensive. So if a patient is on no meds, or they're only on one med for hypertension, it probably is not worth it. Again, you can change your mind every year. You can enroll or disenroll. But once you make up the patient makes up their mind, they're stuck with their decision for a year until the open enrollment period. Part D, there's a variety of subsidies available for low and limited income beneficiaries. There's premium and deductible waivers. Their co-payments are nominal with generics used more than brands. Covers most FDA-approved prescription drugs and biologicals, not including those covered by Medicare Part A and Part B. Provider plans are allowed to have formularies and tiered cost sharing if deemed too restrictive. Prevents Medicare from negotiating discounts directly with manufacturers. About 90% of beneficiaries now have the drug benefit. But again, you may have a discussion with your patient or patients about whether that's a good idea or not. From inception, Medicare expenditures, the number of beneficiaries has increased from 19 to 55 million. So out of about 300 million, that's a good chunk of people on Medicare. Expenditures have grown from 6 billion in 1968 to about 600 billion in 2014. So you can see that's a good chunk of the GDP. Payments for physician and inpatient hospitals services account for about 35% of Medicare payments. Payments for outpatient prescription drugs are about 11% of expenditures. And within Medicare, a relatively small group of patients with serious medical problems accounts for a disproportionate amount of expenditures per beneficiary. So within Medicare, there are a small amount. When we start talking about Part D next year with the pharmacy management course, we'll talk about this relatively small group of patients and how you as a pharmacist can work with this small group of patients to bring down these expenditures. Medicare pays for less than half of the average beneficiary's healthcare bills. 75% of beneficiaries have additional coverage other than traditional Medicare. Other retire benefit from own or spouse's employer, Medicaid, managed care plan, Medigap, private plan that covers many of the charges not covered by Medicare. So Medigap is that Part C. Other retire benefits like with the military, I talked about TRICARE. There's a lot of expenses that people incur after they turn 65 that aren't paid for by Medicare. So again, Medicare pays for less than half of the average beneficiary's healthcare bills. I think I read something in USA Today recently that a couple who's retired older than 65, they can plan on paying out of pocket something like $300,000 before they die, a couple. So that's about $150,000 each. So you really need to have some money in your retirement account before you retire, other than just Social Security and Medicare. Most states have regulations to make it easier for seniors to compare Medigap plans. Many types of policies allowed, plans A through N. Plans B through N offer a variety of additional or enhanced benefits. So if you're talking about these Medigap plans, you as a pharmacist, you have access to a website. You can look at these different kinds of plans that are offered, like by AARP, Humana, and so on. And they're categorized with this letter A through N. There's standardized formats, language, and definitions. All states must allow Plan A, the basic, which must be offered by all Medicare, Medigap insurances, but they do not have to offer any other plans. Most basic Medigap policy Plan A covers copays for days 61 through 90 of inpatient hospitalization, copay for lifetime hospital inpatient reserve, 100% of Medicare eligible hospital expenditures after Medicare benefits are exhausted, 3-pint blood deductible, and Medicare Part B coinsurance. So again, think of these Medigap as a second payer. The first payer is Medicare, and then these Medigap pay is a second payer that is kind of like a secondary source of payment from patients if they have these programs. I've enrolled in them. Now, switching gears, we've got another half of this. Again, this is a log pack podcast. I apologize, but we need to cover Medicaid. Title 19 of the Social Security Act grants to states for medical assistance programs, often known as Medicaid, was passed in 1965 to provide medical assistance to eligible needy Americans. Title 19 was a last-minute addition to the 1965 bill with no real estimate of future costs. It was expected to be a stopgap or temporary measure until universal health insurance passed after a larger Democratic majority with another Democratic presidential win in 1968. However, Richard Nixon, a Republican, won in 1968. The universal health insurance movement stalled. Medicaid is now the largest source of funding for health-related services to low-income Americans. with welfare reform, the Personal Responsibility and Work Opportunities Act of 1996 removed automatic eligibility for individuals who receive cash welfare through aid to families with dependent children. It successfully cut off the link between Medicaid and cash welfare by replacing this AFDC with the Temporary Assistance for Needy Families program. This TANF provides block grants to states for time-limited cash assistance, and it allows families to receive cash welfare for no more than 5 years, and allows states to impose other requirements related to employment and education. Since Medicaid is a joint state-federal program, states have flexibility to determine criteria within federal guidelines. 3 broad groups may be covered by Medicaid: mandated categorically needy, the optionally categorically needy, and the medically needy. So again, we're talking about criteria that are developed by the federal government that the states have to follow. So they may cover people in one category, but they have the option to cover other people in other categories. So the states have some flexibility in who they serve. Families below a state-determined maximum limit on income and services. This is the mandated categorically needy. That first class, this is the one that almost all states provide care to. These are families below a state-determined maximum limit on income and resources. A child living with a parent or other relative that is deprived of parental support or care due to a death, absence, incapacity, or unemployment. Individuals receiving cash assistance through the Social Security program below income and asset limits. So bear in mind, you can very well, if you're over 65, be getting Medicare and getting Medicaid, so you're dual eligible, so to speak. Pregnant women and children under the age of 6 below certain income limits. All children less than 19 and families below the federal poverty level, and qualified Medicare beneficiaries below certain income and asset limits. The next category is the optionally categorically needed. It's determined by states. So although they have to cover the mandated categorically needy because of federal guidelines, they don't have to cover those in the optionally categorically needy. Again, this is determined by states. They do not meet mandated requirements, but share certain characteristics with the mandated categorically needy and must receive the same benefits as the mandated group. Again, this is determined by states. They don't have to do this. Medically needy is optional. It's determined by states. It would be eligible in other 2 groups except they exceed the income or asset limits. Medical expenses reduce net income to below the thresholds. A good example of medically needy is people that are over the 65. For example, an elderly couple, they have some retirement funds in a bank. The husband dies. The wife has spent more than half of their retirement income funds, and what she needs to do before she qualifies for Medicaid in their state, she needs to spend down that retirement, those retirement funds. So if she needs to go into a nursing home, she has to pay out of her retirement funds the nursing home fees for her bed and so on, food. But when that retirement funds get down to really very low, then Medicaid will kick in, and only then. So it's a spend down type of affair going on. It's used mostly to grant eligibility to institutionalized persons who incur extremely large medical expenses like nursing facility patients. If available, you must also cover certain minors and pregnant women that would be eligible, except they exceed the income or asset limits. Now, forgot to mention there's an IRAT from this particular slide. I want you to know what medically needy means. And that it refers to individuals who spend down to Medicaid eligibility by incurring high out-of-pocket medical expenses like nursing home care. Moving on to state flexibility. States must operate Medicaid programs within broad guidelines and adhere to 3 general requirements: state-wideness, in effect throughout the state without variation, freedom of choice, able to obtain covered services from any qualifying provider, and comparability of services equal for all beneficiaries. Under SSA, CMS, Centers for Medicare and Medicaid Services, can grant 2 types of waivers. Section 1115, it's a 5-year demonstration waiver for innovative ideas, must be budget neutral, does not increase costs, but increases eligibility or provides new benefits, and mostly have been managed, they're part of these managed care demonstrations. Section 1915B targets only current beneficiaries, will not expand eligibility to implement managed care principles. Over 60% of Medicaid beneficiaries are enrolled in managed care, so they're part of MCOs. Now, this may seem confusing to you, but these waivers, the federal government mandates that certain things be done. You can get waivers if you're one of these managed care organizations to do different kinds of things, but they have to be, for example, budget neutral. Financing and administration. There's an IRAT that comes from this particular slide, so be careful. It actually comes from the 4th bullet here, but we'll read through this. Medicaid is actually an optional program. It is not required of the states by the federal government. A state would be foolish to do this. It's like free money. So if they put up half, usually the federal government will match it. That's a good deal. So it's actually an optional program, but all states take part in this. Federal and state governments share financing and administration. The Centers for Medicare and Medicaid, and a single agency in each state, which requires administrating the program. States determine eligibility other than those mandated, scope of services, and provider payment rates. The federal portion of Medicaid program costs, the federal medication assistance percentage, is determined by comparing a state's average per capita income to the national average by law, a maximum of 83%, a minimum of 50%. So a good example, a poor state like Mississippi or New Mexico, if they put up half, they don't actually put up half, they put up some money and it may get matched at more than 50%, like 83%. Whereas a richer state like New York, Minnesota, they put up half, they'll only get matched at half. Administrative costs are split evenly, and providers must accept whatever amount Medicaid reimburses as payment in full. So if you're a physician, you have to accept whatever Medicaid reimburses as payment in full, and sometimes that's very little. So a lot of providers in some states like California don't even participate in Medicaid. And that's opened the door for pharmacists getting involved in the care of Medicaid patients in California. We've discussed that before. I want you to know, focus in on that fourth bullet for the IRAT. I want you to know that 83% is the maximum allowable federal medical assistance percentage. We talked about that for poor states getting funds from the federal government. Sort of a matching going on. Required services covered. You can read through these: inpatient hospital services, outpatient hospital services, physician services, rural health clinic services, federally qualified health center services, labs and x-rays, nursing facility services for individuals greater than or equal to 21 years old. Again, you may be talking about elderly that have spent down their savings retirement fund before they qualify for this. Early and periodic screening, diagnosis, and treatment for individuals less than 21 years old. Family planning services and supplies. Home health services for persons eligible for skilled nursing services. Nurse midwife services and certified pediatric family practitioner services and prenatal care. So a lot of Medicaid is focused in on young women having children as well. Optional services are covered, and again, this is up to the states to determine: outpatient prescription drugs, prosthetic devices, physical therapy, rehabilitation services, optometry services in an intermediate care facility for mentally retarded, transportation services, home and community care-based care for certain persons with chronic impairments. So again, it's up to the states. A lot of states will provide outpatient prescription drugs because if you give a patient an inexpensive generic drugs, that often can help keep the patient out of more expensive care that is provided only in a hospital. Medically needy program services include prenatal and delivery services for pregnant women, ambulatory services to individuals less than or equal to age 18, and those entitled to institutional services, home health services for those entitled to nursing facilities. Cost sharing. Again, we've talked about this a lot. Many states have Medicaid recipients These states contribute to the cost of their health care by deductibles, co-payments, and co-insurance. Be careful about this bullet. Medicaid recipients, many times when you're serving them at the pharmacy, it may say right on their card that they have to pay deductible, a copay, but it also says on that card they can say to the pharmacist, I can't pay this $5 for a generic or $10 for a brand name. I can't pay it. And the pharmacist will make a note and bypass or not charge the Medicaid recipient. So although it says here Medicaid recipients contribute to the cost, that's kind of on a case-by-case basis. Cost sharing cannot be so great as to be a barrier to needed services, well, that's what I'm talking about. The patient needs the prescription, you can waive the copay, so to speak. Over 80% of states have copayments for outpatient prescription drugs, but most range from 50 cents to $3. Again, that depends on the state. Again, those can be waived. Nursing home patients are expected to contribute most of their income to help pay for their care. Cost sharing not allowed for emergency care, family planning services, pregnancy-related services, and services provided to those less than or equal to age 18. So for those folks, they don't have to share that cost. Finally, this last slide, there'll be an IRAT that comes from this slide as well, so listen up. Medicare beneficiaries are about 20% of the U.S. and going up. This is about 60 million people out of 300 million approximately at a cost of more than $400 billion annually. So this is an extreme cost that our country has to bear. Children are 52% of these people, but only 20% of expenditures. The blind and the disabled are 16%, 45% of the expenditures. The elderly are 8%, but 22% of the expenditures. So when you're talking about Medicaid, you're mostly talking about the blind and the disabled. Distribution of payments by service, about 12% by nursing facilities and about 14% by inpatient hospital. Now, I really want you to get from this for an IRAD that the blind and the disabled account for the largest percentage of Medicaid expenditures. And with that, this podcast is done.